And we are live, sir.
Good evening, everybody. And probably we'll have a few more later. So let's start it on time. So welcome you all to this webinar on adult respiratory vaccination, which is a joint endeavor from National Allergy Asthma Bronchitis Institute, Kolkata, and fortunately, Indian Chest Society. It's quite cold outside in Kolkata now. I think it will be more in Delhi and probably further in Kashmir. And so it is the time to discuss vaccination. And of course, the whole pandemic constantly reminded us the need for vaccination. Practically, the acceptance of adult vaccination took a little more time compared to other countries in India. People were skeptic at first. I still remember one title, one publication where science ends and commerce begins about vaccination. And then the awareness grew up. And in 2016, Nobi brought a position paper on adult respiratory vaccination. After that, we understood that we need a bigger stage and better acceptance. And to make that possible, it's nothing better than to bring our mother organization, Indian Chest Society. The attempt to develop easily implementable clinical recommendations was undertaken as a joint exercise by the Indian Chest Society. Fortunately, National College of Chest Physicians of India also joined, and we all together had a meeting of experts in Kolkata on 13th January 2019. There were 24 experts and 4 moderators. The expert panel members included different parts of India and different specialties: pulmonologists, nephrologists, diabetologists, and immunologists, all together, very brainstorming session. Then we came out with the publication this year in our national journal Lung India, April 2020. But even after the publication, we got several queries, comments from all over the globe, actually, not only India, where we faced some questions, some explanations, some comments. And we thought it would be good to have a webinar so that we can discuss among ourselves also where are the ambiguities in our approach, if any, and to make them clarification. So I think everybody has not joined yet, but I still welcome whom I have seen, Dr. Georgi Abraham, Rajesh, our own people, Rajesh Sannakar, Dr. Parvez Kaul is always there. I don't even remember that he is from Kashmir. Dr. our own people, Raja Dhar and Inul Haldar, who are faculty of National Allergy Asthma Bronchitis Institute, Novi, Kolkata. We are expecting Dr. Randeep Guleria, and all together. And probably we are also expecting Subramaniam Saminathan. I have not seen him yet. So let's go to this. And the flow is like this. Next, I will request Dr. Rajesh Sarnakar, Honorary Secretary, Indian Chest Society, to bring out the concept of bringing these guidelines. And then Raja will have a brief talk and introduction on adult pneumococcal vaccination, followed by Dr. Indra Haldar, influenza vaccination, and then the most important panel discussion where we will interact and then dissect out what are the pitfalls, ambiguities, confusions that remain. We need more awareness and more acceptance of this adult respiratory vaccination. jointly by National Allergy Asthma Bronchitis Institute, Kolkata, and Indian Chest Society with National College of Chest Physicians, India. So I request Dr. Rajesh Chandokar to next start with.
Yeah, so thank you, Dr. Ghoshal, for a nice introduction. So I welcome you all on this Indian Chest Society and Navi Association for this very good webinar on adult vaccination. To just give you the right perspective, several evidence-based global guidelines and also the recommendation from the numerous bodies are available for this influenza as well as pneumococcal vaccination for the diverse adult population. However, due to the difference in the disease burden and also regulatory landscape, healthcare infrastructure, and also functioning in India, these also global guidelines cannot be implemented just in our region like that. So hence, for the absence of this country's specific structural clinical recommendations on adult respiratory vaccination, this document is a first of its kind, actually multidisciplinary effort to also lay down the specific evidence-based all sort of recommendations on adult as well as influenza, as well as pneumococcal vaccination for this country. It has got aim to guide actually practicing clinicians and healthcare professionals in the country from also various specialties to make this informed decision about adult respiratory vaccination and to facilitate consistent adult respiration vaccination in the region, and also further help to also reduce this critical burden in this country. This is the pioneering attempt to develop easily implementable clinical recommendation for the prevention of pneumonia and influenza vaccination in India. And as also Dr. Ghoshal said, it was undertaken as a joint exercise by Indian Chest Society as well as National College of Chest Physicians of India by a panel of experts. And we just came out with this. It is the first time that we had such guidelines for our country, and we are going to have to dwell in this topic. We got next, I think, 1.5 hours or 2 hours to do this. So I would hand over to Dr. Raja to have some of the information on this, and then we can have a stimulating panel discussion. So Dr. welcome you all, and hope that you would enjoy this webinar. Thank you.
Good evening, Dr. Guleria.
Welcome, Dr. Guleria. I don't know whether he can hear us or not, but we'll start off. Can everyone see
my... Good evening. I hope you can
hear me. I can hear you loud and clear. Thank you.
Good evening.
Thank you. So are the slides visible?
Yes, it is.
Okay. So over the next 12 odd minutes, I'm going to speak about the adult pneumococcal vaccination. You've heard the background, so I won't dwell on the background anymore. What I'm going to do over the next 12 odd minutes is to tell you verbatim from the guidelines as to what the pneumococcal section of the guidelines talked about. And then my friend and colleague, Dr. Indranil Haldar, will speak about the influenza segment. So that's the document. That's the pneumococcal vaccination segment of the document from Lung India. And the highlighted names are people who have joined us today for this particular webinar. So you can see we have managed to cover quite a lot of people who were the heart of this particular document. So a little bit of background, just some numbers which again are from the guideline and establish the requirement for having pneumococcal vaccination guidelines in India. So India accounts for 23% of all of the global pneumonia cases, which in turn amounts to a whopping number of 43 million cases. And for the less than 5-year category, the World Health Organization thinks that 36% of the cases of pneumonia are from India. The overall estimate of annual incidence of community-acquired pneumonia is anywhere between 2 and 12 cases per 1,000. And predictably, the highest numbers are in infants and the elderly. The mortality in India, thankfully, is not very different to what it is for the rest of the world. So 1 to 5% for outpatient setting, 12% for hospitalized setting. And what that slide does not talk about, but is important, is it's as high as 30% for patients who are admitted to intensive care. We understand that the landscape of antibiotic resistance has been developing over the past decade or even 2 decades. And hence, preventive strategies like vaccination, pneumococcal vaccination in this case, would be the only way to improve disease protection, to improve control of this disease going forward. And hence, vaccination of any sorts, and we, like Dr. Ghoshal mentioned, have thought about this repeatedly going through the COVID-19 pandemic, is useful in any country. And pneumococcal vaccination with the numbers that I have just shown you is no different. Even beyond mortality, there are other benefits, a lot of other benefits which are important. The fact that you decrease the usage of antibiotics. If you decrease usage of antibiotics, you end up reducing antibiotic resistance. You reduce total healthcare cost by reducing admissions, hence financial protection, and then the herd immunity, which again, you've heard about repeatedly throughout the COVID-19 pandemic, but which seems to never have transpired till date. The next thing I want to focus on is about the age group. And this is important because going forward, both myself and Indraneel, and then as a panel discussion, we'll talk about the right age to vaccinate. And there is controversy which is rife about the age factor. So if you look globally, if you compare between adults between 18 to 49 years of age, between 50 to 64 years of age, there's a 4-time higher risk of pneumonia. Between 65 to 79 years of age, there is a 9-time higher risk of pneumonia. And above the age of 80, so 80 or above, the risk goes up by a huge number of 25 times. Hence, we understand that 50 is one cutoff, 65 is one cutoff, and we need to balance which age is the right age in vaccinating the population. And we'll come back to this as we go along, both in this talk and in the panel discussion. The annual incidence of pneumonia reported among adults between 60 to 79 years is 63 cases. And you can see as soon as you go beyond the age of 80, this number becomes 2.5 times that of 63. So about 165 cases per 10,000 adults. And in India, similar increase in incidence rate has been reported with increase of age. The incidence rate of strep pneumonia higher in adults aged more than 60, about 31%, in comparison with a lower age group or a further lower age group. So between 44 to 60, 22.7% is what you're looking at. And in adults between 18 to 44, about 14% is what you're looking at. So why is this important? It is important because pneumococcal pneumonia often results in invasive pneumococcal disease. And when you're vaccinating people, what you're really trying to prevent in the way of reducing mortality is preventing invasive pneumococcal disease. This is a common bacteria, as you all know, which is isolated from children, also in patients with bacterial pneumonia, which is the topic of discussion today, and with pyogenic meningitis. And if you look at meta-analysis, one coming from India, the incidence of invasive pneumococcal disease was between 10 to 11% in children admitted to hospitals with suspected invasive bacterial pneumonia and 24% of all bacterial pneumonia. Let's then talk briefly about dose and route of administration. We won't dwell on this for long. All of us know that there are 2 inactivated pneumococcal vaccines that are available. The first is the conjugate 13-valent vaccine, eponymously called the PCV13, and then the 23-valent pneumococcal polysaccharide vaccine, eponymously called the PPSV23. This is the table which is directly from the actual document. And again, without trying to labor over this, for PCV13, the administration is IM, intramuscular. In case of children, you would do it in case of infants, you would do it in the anterolateral aspect of the thigh. In case of children and adults, you would do it in the insertion of the deltoid, and you wouldn't do it in the gluteal region for the risk of injury to major nerve trunks like the sciatic nerve, which lie there. They mainly come as pre-filled syringes of 0.5 ml of suspension. However, there are some multi-dose vials which are also available, which are used to administer the vaccine to multiple people at a time. And when you're preparing for administration, because this is a suspension containing an adjuvant, you shake vigorously to produce a homogeneous suspension before you actually administer the vaccine. We have talked about the route on there. This is about PPSV23. And again, similar the way you do it for PCV13. So it's given IM or subcut. Again, dose of 0.5 ml. And it should not be used if there's any particulate matter present or any discoloration that's noted. So that's the important part to remember for this particular section. What about contraindications? Again, very quickly, hypersensitivity to any component of the vaccine is of course important, and that's true for any vaccine, not just the pneumococcal vaccine. If you are in the middle of an acute respiratory illness, you're better off avoiding vaccinating at that time, even though evidence for this is not very robust. Obviously, if your immune competence is low, and there's a list of things that you see on there, which we'll speak about again when we talk about indications for vaccination. So immunosuppression in the way of asplenia, which can be congenital or acquired, HIV, malignancy, etc. For all these factors, they have reduced antibody responses to immunization with pneumococcal vaccine. So this is not a contraindication to vaccination, but just to say that the response to the vaccine in this group of patients is going to be lower. In pregnancy, there is no contraindication. However, there is a lack of recommendation because the vaccines, both these vaccines, have not been trialed in the pregnant population, and hence the safety data is inadequate in this population. The use of pneumococcal vaccine in solid organ transplant is again not contraindicated, and again, there is less data in this group. There's thinking about whether rheumatoid arthritis might be a contraindication, both because of the disease process and because of the drugs that you use. And again, it's been found that this is not a contraindication for this population of patients. So this chart tells you more about what we have just discussed. And again, this chart is straight from the document. And I would encourage you to go through this chart to remember about the contraindications and the areas when you need precautions with PCV13 and PPSV23. The next question to be asked is whether the co-administration schedule with other recommended vaccines, what are the vaccines you can administer this with, and where do you need to be more careful? So the most important one is right at the top. So PCV13 can be concomitantly administered with both the trivalent and the quadrivalent influenza vaccine. So these vaccines go well together, and there is no contraindication of giving both vaccines at the same time. For tetanus diphtheria, for diphtheria tetanus pertussis, for hepatitis B, influenza type B, all of these vaccines can be concomitantly administered with the PCV13. And when we say they can be concomitantly administered, they can be done at the same visit. Obviously, you would use separate syringes and separate anatomical sites. However, there's no waiting period required between these two vaccines. And if you want to do it later, again, there's no recommended time frame or time gap between administration of the two vaccines. Now comes the most important question, which comes first? So we've talked about two different vaccines. So which vaccine comes first, and what's the vaccination schedule in India? And we start off with adults aged between 19 to 64 years of age. So pneumococcal vaccination is not recommended for the completely healthy adult under the age of 65. So it's only above 65 that we have recommended the use of this vaccine if you do not have any comorbidities, concomitant illness, you're not a smoker, and so on. So in immunocompetent patients with chronic conditions like chronic heart disease, chronic liver disease, poorly controlled diabetes, and you can see the list on there also includes current smokers, alcohol abuse, etc. It's a single dose of PCV13 followed by PPSV23, and this time gap is important. More than 8 weeks is what is recommended. In adults with a history of invasive pneumococcal disease and those with cochlear implants, CSF leaks, and again, congenital or acquired immunosuppression. So it's asplenic individuals, patients who are hyposplenic, sickle cell anemia, etc. A single dose of PCV13 is followed by PPSV23. If you look at the immunocompetent conditions versus the vis-a-vis the immunosuppressed condition, the vaccine is both vaccines are more strongly recommended in the immunosuppressed condition as compared to immunocompetent. However, we have chosen to recommend both vaccines in both the immunocompetent condition with comorbidities and the ones, obviously, with immunosuppression. The last group, as I mentioned already, is patients who are immunocompromised individuals, and we have spoken about congenital and iatrogenic immunosuppression and those with HIV infection. So this again is a chart straight from the guideline, which talks about the detailed schedule for administration of risk-based pneumococcal vaccination of adults between 19 to 64. And I won't dwell on this because we have discussed this already. Now we come to the second group, where vaccination is probably deemed to be even more important. So these are adults aged 65 years or older than that. And this is the group where PPSV23 is an absolute must. So PPSV23 is strongly recommended in this population because the overall higher incidence of invasive pneumococcal disease in this group of patients. So again, in individual patients, you would want to discuss the risks and benefit. You will offer PCV13 followed by PPSV23 in these groups of patients. And the same guideline goes for chronic conditions. We've talked about these chronic conditions before. The other important factor is that repeat vaccination with PPSV23 causes hypo-responsiveness, and hence revaccination of individuals with PPSV23 is based on individual patients and clinical judgment and should be based on a discussion between the patient and the physician. So this again is the chart for 65 years or above, and this just charts out what we have discussed already. So what about travelers? And the working group for prevention of pneumococcal disease in Hajj pilgrimage was recommended to administer PCV13 4 weeks before travel to Hajj and PPSV23 administered after return from Hajj. And we said in the guideline that any pilgrimage, be it the Kumbh Mela or any other area where you have pilgrims congregating together in large masses with large gatherings, the same recommendations as Hajj pilgrims should be followed. The other question, which we'll, I think, discuss again in the panel discussion, is why is PCV13 to be administered before PPSV23? And that's because the vaccine, the PCV13 vaccine, amplifies the anti-pneumococcal effect with subsequent administration of PPSV23. And the T-cell response of PCV13 results in immunological memory induction and long-lasting memory. What about patients who have received PPSV23 first? So you've received PPSV23 before, and the patient then comes to you thereafter. So you should have a gap of at least 1 year and then administer PCV13. And then 5 years down the line, you can think about administering PPSV23 in these individuals. Co-administration, we've talked about this, a gap of 8 weeks to be maintained between the two vaccines. That's an absolute must. And we have discussed all of this. Vaccination cards are important, and we have stressed on this in the document. Having vaccination card acts as an aide de memoire and improves compliance both from the healthcare worker and from the patient in ensuring vaccination. So in summary, I think we have covered the fact that a high proportion of patients with strep pneumonia have been reported in Indian population, and these patients have a higher mortality. In view of emergence of antibiotic resistance, a preventive strategy is important, and hence pneumococcal vaccination becomes very important. We have two vaccines which are available to us. The age group for which it's approved is different, and it's on that slide. But these vaccines go hand in hand rather than being competitive with each other. Need to make sure that the vaccines don't contain particulate matter before you inject them, and the fact that there's an unmet need for vaccination for pneumococcus, and we've discussed the wide array of areas where normal individuals without any comorbidities, comorbid conditions, and immunosuppressed individuals can be vaccinated. Thank you very much for listening in. And I'll hand over to my good friend and colleague, Dr. Indraneel Haldar, to do the influenza vaccination talk.
Thank you, Raja. That was precise at least. And then we may have to repeat some of this during our panel discussion, because after all, we have to spread the message. So Indraneel, now with your adult influenza vaccination.
So thank you, sir, for your kind words. And I'll go straight to the influenza vaccination because the introductory part has already been done. And I will be telling more relevant and important things which are there in the document. Just to have a stress on the disease itself, the influenza, which is highly contagious with an annual attack rate of anywhere between 5 to 10% in the adult and about 30% in children. But those in the healthcare worker, it is more than 50% those dealing with influenza patients. There is affected severely to the tune of 3 to 5 million per year globally, and with a huge mortality. And no age is skeptic from the disease. And in fact, there are some vulnerable, which include children, patients with chronic disease, pregnant ladies, healthcare workers, and in the elderly, and WHO has recommended vaccination group accordingly. So to highlight the burden of the influenza disease globally and in India, and we have the 4 main varieties of the influenza virus, A, B, C, and the D. The seasonal flu endemic are caused by the human influenza virus A and B. According to the recent global estimate, influenza account for substantial mortality, which claims about a 6 lakh death annually. Coming to some of the Indian data, although there is dearth of robust data on the disease burden in India, according to one of the estimates from the studies, it has been 2010 to 2070, over 1 lakh cases and 8,000 deaths were reported due to influenza in India. According to the Indian Regional Surveillance Study, the incidence of influenza hospitalization is as high as 46 per 10,000 patients. And in these studies, seasonal influenza type A and B were the predominant variety of influenza. Just to give a brief idea about the influenza A and the influenza virus and about the nomenclature, the influenza A, there are 80 different hemagglutinin subtypes, this one and 11 different neuraminidase subtypes, H1 through H18 and N1 to N11, and the nomenclature is according to the place, the year, and the this HA and the NA. The influenza B virus is further broken down into lineage and strains, and currently at that time there are 2 main influenza B virus, the Yamagata and the Victoria. Coming straight toward the vaccine, the injectable vaccine that we have is either the trivalent or the quadrivalent. Whereas the trivalent vaccine contains 2A influenza and 1B, the quadrivalent contains 2A and the 2B. Now the question was that at the time of the documentation of the document that was done, the recommended influenza vaccine for the northern and the southern hemisphere were different. And according to the WHO, the northern hemisphere, this was directly taken from the document, the quadrivalent vaccine and the trivalent vaccine in the northern hemisphere, and from the southern hemisphere, the quadrivalent vaccine and the trivalent vaccine. We can see that in the southern hemisphere, the Phuket variety, the type B, has been added, and in fact, in the northern hemisphere, here also in the quadrivalent, the Phuket variety has been added to the trivalent vaccine. The question again came, what was the rationality for the quadrivalent influenza vaccine? That is, why is it important that an adding B strain added to the trivalent influenza vaccine improved the outcome in that way? So the impact of the trivalent influenza vaccine was undermined by that there was a mismatch due to inaccurate prediction which type of B lineage will be there. And there were also co-circulation of both type of B. It was not definite. They cannot predict. WHO collecting data from the different sites cannot predict which type of B virus was circulating. And the triad of 2 lineage co-circulating with enough disease burden, and also that there was limited cross protection between these 2 B type, and inability to predict accurately which type will be circulating. So the decision was to have both type in the vaccines. So the quadrivalent influenza vaccine has an advantage over the trivalent influenza vaccine. The real problem or the real question of having the regional vaccination guideline was which vaccination, whether the southern hemisphere or the northern hemisphere vaccine is to be followed, and what was the real time of giving the vaccination. It is geographically that India falls in the tropical and in the subtropical region in the northern hemisphere. But if we see laboratory-based surveillance data from WHO FluNet database created to ascertain the peak of the influenza circulation in 125 countries, and have revealed that 30% influenza positive rate in December, May, and 70% positive rate in June, November in India. Evidence from a study examining the relationship between the influenza positivity and the latitude revealed that, as against the typical northern hemisphere pattern, which is expected because we are staying in the northern hemisphere geography, but Indian cities which are located north to 30° north latitude and which has a late monsoon season had influenza peak in the winter. Whereas those cities located south of 30° north had seasonality during the summer months, that was in the July to September. Hence, for the recommendation of influenza vaccine, it was essential to consider the local epidemiological data for influenza peak seasonality rather than on which hemisphere we are doing. So with this, as I told, that July, September in cities like Delhi, Lucknow, Pune, and the Alipurduar, Nagpur, Kolkata, and Dibrugarh all followed the July-September trend. Chennai and Vellore, which are lower down, had a October-November coinciding with the monsoon. But unlikely to that, Srinagar, northernmost of the city, the influenza circulated peak in the January-March, that is the winter city. So while cities with temperate seasonality will benefit from the vaccination in September-October, cities with peak in the monsoon season in July-September will benefit from vaccination in April-May. And this was a great discussion which took place and it was documented in the study there. So this is in map, we find that the green zone are this one which this timing, the ideal timing for the influenza vaccination, the September to October in the green zone, that is the Srinagar up northern part, Chennai and Vellore, whereas the other parts of India, it is in the April-May, that is Delhi, Lucknow, Kolkata, Dibrugarh, and Pune. Now coming to the various type of influenza vaccines that are available. Presently, inactivated trivalent and quadrivalent influenza vaccines are commercially available and they are recommended for the clinical use in the Indian population. But another vaccine which was indigenously developed in India was the one that was live attenuated seasonal influenza vaccine. It was intranasal. Although the safety of the live attenuated seasonal vaccine, which was intranasal, was reassuring, and there was paucity of data on whether this vaccine was as effective as the contemporary injectable influenza vaccine across various age groups was there. Unfortunately, the vaccine was withdrawn from the Indian market, and hence there is no choice but to give the injectable influenza vaccine. Now, what was the recommendation? For the prevention of influenza in India, two vaccines are available. That is the standard dose trivalent influenza and the standard dose quadrivalent injectable influenza vaccine. Despite the availability of robust Indian safety data and the safety of the live attenuated influenza vaccine, the nasal one, the panel recommended the use of injectable influenza vaccine over the live attenuated one, and unfortunately it is not also available. The expert ultimately recommended that the use of the quadrivalent injectable influenza vaccine over the trivalent in developing nations such as in India, and the reason behind it was already explained in my previous slide. Coming to the contraindication, which has been directly taken from the publications, that is the contraindication is if there is a previous severe allergic reaction to influenza vaccine, regardless of the component suspected of being responsible for the reaction. Now there are precautions which are to be taken. Precautions include moderate or severe acute illness with or without fever, and if there is a history of Guillain-Barré syndrome within 6 weeks of recipient of the influenza vaccine. Now again, the question came up whether individuals who are having egg allergy, Guillain-Barré syndrome, multiple sclerosis, or on antiviral therapy, or on steroid therapy or statin therapy, whether they can be given the influenza vaccine or not. So in summary, patients or the subjects who are having an allergy to egg or experiencing reactions to involving symptoms of allergy, they can be given age-appropriate influenza vaccine. So influenza for patients who have a previous history of Guillain-Barré, the expert recommended against the use of influenza vaccination in individuals who are not at higher risk for severe influenza complications and known to have experienced Guillain-Barré syndrome within the next 6 weeks of previous influenza vaccines. Patients with multiple sclerosis, the expert recommended standard dose of the vaccination, injectable one. Patients on antiviral therapy, the experts recommend that they can be given. Patients on corticosteroid therapy, again, patients who are on long-term corticosteroid therapy because of any form of chronic pulmonary disease, they can also be given the vaccinations. Coming to the statin, it has been acknowledged that statin has the propensity to reduce the effectiveness of the vaccine, but nevertheless, the use of influenza vaccine in this patient is recommended. Now coming to the co-administration of these vaccines with other vaccines, for example, other live vaccines. In line with the evidence, the expert accepted that and recommended that injectable influenza vaccine can be concomitantly or sequentially administered with other inactivated vaccines or with live vaccines. So if pneumococcal vaccination is given, as already Dr. Raja told, that it can be given simultaneously in 2 different anatomical slides and 2 different syringes are to be used, and with a very strong evidence in favor of it. So coming to the dose and the frequency of the influenza vaccination that we came out, among the standard and the high dose, again, the high dose vaccination is not available in India. The high dose vaccination contains the higher amount of the vaccines, and it is available in some part of the countries like USA, and it has high immunogenicity effect. Of the standard and the high dose of the influenza vaccine, evidence reveals significant increased level of antibody response by the high dose compared to the standard dose of vaccination without any increase in the adverse effect. And the expert recommended a single dose of the injectable influenza vaccine when available for Indian clinical practice. And in view of the dearth of evidence comparing a single dose annual influenza vaccine and the biannual influenza vaccine, the recommendation is that annual influenza vaccine is to be given. Now, which age group the vaccine is to be given? So again, here the cutoff is done at 50 years, though there are other recommendations above 64 years. And the reason behind is that the people in the developing countries like India, more than 50 years, are at higher risk of developing influenza to the tune of more than 4 times than the other lower age group. So whereas 18 to 49 years, 1 dose of annually can be given, the choice of vaccination to be administered is based on the discretion of the doctor and patient while vaccinating individual. And above 50 years, vaccination is strongly recommended for patients at higher risk of influenza. So coming to the vaccine recommendation for adult at high risk of influenza in India, and this has been taken from the document itself. So whereas diabetes, renal disease, there the evidence 2A, chronic liver disease and liver transplant 3A, but patients who are having heart disease, there is a strong evidence of 1A. Neurological condition is the usual practice point. Hematological conditions like sickle cell aspenia, again, is evidence of 1B, including people who are living with HIV, that is patients with HIV. Cancers, pregnancy, again, pregnancy, there is guidelines that all pregnant ladies to be given the influenza vaccine. Coming to the one that we are really concerned is chronic respiratory disease, except for asthma, that is COPD, bronchiectasis, ILD, and chronic smoker, there is a 2A recommendation, but also an usual practice point for patients who are suffering from asthma. Coming to the recommendation for healthcare worker, there is a strong evidence that all healthcare workers should be taking this vaccination. And here the definition of healthcare workers include all medical personnel, paramedical personnel, persons who are working in screening centers, also treating, managing high-risk patient, laboratory personnel, rapid response team, and in fact, the driver, staff of vehicle, ambulance involved in the transfer of the influenza patients should be included. A few words about mass gathering, Hajj and Kumbh Mela. Religious festival, which include the major one like the Hajj and the Kumbh, including huge participation from the pilgrim coming from around the globe, and can potentially lead to transmission of this infectious disease among these pilgrims. Hence, both India, who are sending the pilgrim, and the host country healthcare bodies recommend influenza vaccine to all pilgrims and healthcare workers in the Hajj region before they start for their rituals. Although studies on other religious events like the Kumbh are lacking, the recommendation of the influenza vaccine and the data from the Hajj pilgrim might be considered for all religious gathering, including the Kumbh. So influenza vaccine is recommended for individuals, irrespective of their vaccination status, traveling to parts of the world where the influenza activity is going, and it should be according to these places, that whether Northern Hemisphere or Southern Hemisphere, that they are going. The currently administered influenza vaccines should consist the strain that are currently circulated at the travel destination, and the vaccine is recommended to be administered at least 2 weeks prior to the scheduled departure, and this is also the usual practice point. So coming to my concluding slides, that individual regional protocol is very much required for influenza vaccination in India, and the panel acknowledged the need for regional influenza vaccination and unanimously agreed the need for in-depth national surveillance data to observe influenza seasonality in various Indian states. The data will further help forming peak seasonality based on individual recommendation for different parts of India. With its large landmass, the varying geography and varying influenza seasonality, India serves as a perfect example for the development of region-specific influenza vaccination schedule. The regional protocol for individual states based on the surveillance study will lead to greater emphasis on the best period of influenza vaccination administration. So thank you.
So thanks, Indranil. This was both elaborate and precise at the same time. So now we may go to the all-important panel discussion, because there's a large audience who are eager to know individual points, again, at the sake of even repetition. And I will rather start with Dr. Guleria. Dr. Guleria, we understand you have a very busy schedule, and still you have made it to join us. Thanks for that. So may I have the first question to you, that we are talking about and we are listening about pneumococcal burden of the disease, and also antibiotic resistance. And we have some data, some quoted here, some not. They are in the document as well. We have the WHO data, the global burden of disease data, and sporadic reports from different parts of India. So do you feel even this, when WHO calls that the Asia burden and of that the India burden is the highermost, still is actually an underestimate because of low isolation of Streptococcus pneumoniae in sputum or say lavage or in blood samples. Practically, we don't go for bacteriological confirmation in most of the cases of pneumonia, and probably not in all cases of invasive disease. So Dr. Guleria, please.
Well, thank you very much for inviting me. And I do agree with you that we have insufficient data, both when we look at non-invasive mucosal pneumococcal disease or invasive pneumococcal disease. The data itself is not that strong. And I think it's an underestimation of the burden of disease. A lot of times individuals are already put on antibiotics before the testing is done, or it is not done at all. And therefore the actual prevalence becomes something of an estimate rather than actually being able to get exact figures. If you look at data, and there are many studies which have looked at community-acquired pneumonia and tried to identify organisms, it has varied, and on an average, it almost suggests that 30% of all community-acquired pneumonia may be because of pneumococcal disease. But if you critically look at it, number is likely to be much more because a large number of individuals are not tested, or often they've already received antibiotics and therefore you're not able to pick up the infection itself. As far as invasive pneumococcal disease is concerned, there are some studies which have suggested that again the burden is underestimated. We already have an invasive bacterial surveillance group, part of the INCLIN study group, which looked at invasive pneumococcal disease in our country and looked at different age stratification. And interestingly, their data suggested that in individuals over the age of 50, IPD had a mortality of almost 28%, which is very, very high. And that is why it becomes more and more important for us to really aggressively try and prevent pneumococcal disease. Studies from CMC Vellore also, when it looked at IPD over, I think it was a 12 or 15-year study follow-up, again found that despite aggressive antibiotic treatment, the mortality was almost 25 to 30% in that paper. So I think that's important to remember that invasive pneumococcal disease is often missed because your cultures are not positive, and it can lead to significant mortality. And as far as mucosal disease is concerned, often because of antibiotic use, we are underestimating it. The second point that you raised also is very important, that because of the use of antibiotics or misuse, antimicrobial resistance is also going up, and that is why it has to be sort of a very proper management strategy is needed. And if we can decrease the burden of both mucosal and invasive pneumococcal disease, misuse of antibiotics will also come down, and that will also help in decreasing the antimicrobial resistance that we are seeing as a big problem in our country. So I think it is an underestimation, definitely.
Thanks. So can we go to, is Dr. Swaminathan there? Has he joined us?
Very much, sir. Very much.
Okay, so welcome and have a very good evening. Now, may I ask you a continuation of this? So whatever estimates we are getting from different parts of the country, this is a vast country, actually subcontinent, a continent even. So can we take it as a homogeneous representation, or there is actual variability of incidence of Streptococcus pneumoniae in various parts of this Indian subcontinent?
The pediatric data is probably even more clear in that we know there are very good mathematical models out in this respect. What we can clearly conclude is there is no part of India which does not have pneumococcal disease or mortality. That's number one. Second, obviously, in children at least, financial, nutritional status, a lot of other things play into the risk of pneumococcal disease and mortality, and are obviously confounders when you look at how bad the disease is. So Lancet Global Health had a very nice article last year, which looked at the attributable mortality to pneumococcus and H flu. And they showed that states which are underdeveloped in the heartland of the country obviously have more burden in the 0 to 5 age group. Unfortunately, this is only 0 to 5 age group. There is really no good quality data on adults with pneumococcal disease. And I would expect that the risk of pneumococcal disease should not be any different across the country, because again, it ties into the same risk factors that happen everywhere in the world, which is diabetes and heart disease and all that stuff. So if there are no major differences, there should be no major differences, but there could be smaller differences across the country. All in all, yes, pneumococcal disease is something that's prevalent everywhere in India. It may be different in the scale at which you see, but it's still a very, very important issue, and it's not something that we can run away from.
Okay, Dr. Swaminathan, if access to medical care is one of the factors for this pneumococcal mortality, how does it throw light on developing antibiotic resistance? How do you meet this two?
Well, it's a problem, isn't it? See, the point is also that if you look at the US data, since the 1960s, every decade they've been looking at pneumococcal disease mortality data in adults. And the mortality has not come down from over 12 to 13%, even after the arrival of carbapenems like meropenem and imipenem. Basically, increasing antibiotic availability has not reduced mortality significantly. Obviously, not starting antibiotics on time is going to be an issue with regards to mortality. But just because you have antibiotics does not reduce mortality. Nobody's been able to bring it down below 12 to 13% of mortality in pneumococcal pneumonia. So obviously prevention is the only way to reduce the mortality. Antibiotics are not an option. Second, studies have shown, especially from places like Spain, that once you have drug resistance coming in, mortality due to pneumococcal pneumonia will start rising. This is especially so in extrapulmonary pneumococcus, CNS infection, and things like that. But it is a serious concern because at least in CNS infection, we are seeing a significant amount of pneumococcal resistance today, especially in certain age groups. So yes, antibiotic abuse in the community is going to lead to that. Studies have shown that the use of antibiotic in a community will reflect on development of pneumococcus resistance in to those antibiotics. And over time, we are going to select out more and more drug-resistant varieties. So while the percentage which Dr. Guleria mentioned, that 25% sounds really scary, I think if we don't improve systems and possibly cover with vaccination better, I think we should gear up to seeing more mortality than just that much.
So in nutshell, vaccination can help us in both actually, in
Absolutely.
reducing the mortality and in reducing the development of antibiotic resistance.
Absolutely.
Okay, Parvez, any brief comment on this?
So yes, I mean, I would agree with Professor Guleria and Dr. Swaminathan. Yes, there is a clear underestimation of the burden of pneumococcal disease. And we did a study way back in 2015-16. We looked at 225 patients of hospitalized patients with community-acquired pneumonia. And we found that of the patients in whom we actually did beyond what we normally do, beyond the sputum culture and the blood cultures. We looked for urinary antigen, we looked for regional antigen, and we also looked for chlamydia, and also did an RT-PCR for influenza. And we found, to our surprise, pneumococcus indeed was the commonest the bacterial causation for pneumonia, contributing to around 33% of community-acquired pneumonia in hospitalized adults. So this is the study in adults, and we found that it is underestimated, and as such, it is very important to keep it in mind. If you have the wherewithal and if you look for it, probe for it, you're going to find it definitely that the numbers are much, much higher than what we normally believe they are to be.
But about this study, Parvez, just a point, there is a hunch that this tertiary care really represent the field setting for community-acquired pneumonia. The bacteria that you grow there is probably not representative of the real field population.
It is true, sir. I mean, tertiary care would not adequately represent the community, but once we have a surveillance data, we have to have data from across all kinds of care available in our country. And unfortunately, we cannot have that data available, say, from primary health centers or secondary health centers, where even routine microbiological examinations might not be possible, not to speak of high molecular studies. So whatever data we have is from the tertiary care institutions, which probably will have to extrapolate to the community settings.
Thanks. Raja, any brief comment?
No, I agree. I think, like you said, sir, I think the entire population of data that we have is from tertiary care centers throughout the country. And I guess it's the same even globally. I mean, data from primary care, even if I look at England, for instance, if you look at UK, is not a large database. It's the molecular studies have all come from tertiary care centers. And the percentages that we quote, the 30%, 40% that we quote, even globally, comes from data which comes from tertiary care centers. And they might be slightly biased, but all we can do is to extrapolate, like Parvez said.
Okay. Now to Rajesh, coming straight to the actual execution in the field, Dr. Rajesh Chanakar. So they are recommending that the pneumococcal vaccination and influenza vaccination can be given simultaneously on the same time at different sites. So are you happy with this? Do you recommend this, or you say that they should be taken at different times?
No, I think that we are, of course, doing this in our also practice that either of the formulations of pneumococcal vaccine, be it PCV13 or PPSV23. Those, of course, can also be given simultaneously with influenza vaccination. It also saves cost. Administration of more than one of the vaccines should, of course, be done with, of course, different sites. As we say that what we do is that we give it left and right hand, and we then also got a protocol in our hospital that actually before we just discharge the patient after the acute phase of infection is over. So before we discharge, we got a protocol to give these two also vaccination, because this is quite handy. At that time, patient is also quite heeding to your advice that this should not happen again and you should get protected. So all this thing goes actually a long way, in fact. So I would say that we would have to do that, and there are several studies, in fact, which say
So,
that
Rajesh, do you mean we go more unquestioned from patients in India? Whatever you advise them, they do?
Yeah, the thing is that you have to catch them at right time. So I think the right time is when they're admitted with acute exacerbation or also because some with infection. And before they go home, you have to tell that this should not happen again. And of course, we have to tell it, but of course, cost is a factor sometimes. But I think in tertiary centers like us, whenever people come, they would heed to the advice of our tertiary.
It's okay.
So yeah, so
Yes.
it happens. So you have to make them understand that you have just come here. You're now.
As well. Actually, they may be lost to follow up. So it is better to give both the vaccinations together simultaneously.
So I also put a stamp on there. This thing that I had advised them this in this also vaccinated. Even I also remember, and then I can always follow up at the next visit whether he has just taken this vaccine or not. So that also helps. So we have to have some.
I think others also agree that probably it can give in simultaneously on the same day. And again, as I said, otherwise some people may be lost to follow. The vaccination schedule may not be complete. Coming back to Raja, you told that this 13 before 23, but I think the audience needs to get a clearer picture. Why do you recommend this? That if we give both, when you are giving both, why 13 before 23? Raja.
So I'll try and be a bit more detailed, sir. So I think when we are giving PCV 13 followed by the PPSV 23, 8 weeks to 1 year. So after 8 weeks and before 1 year lapses, you're providing protection against 11 pneumococcal serotypes, which are not being covered by PCV 13. There's something else that I want to say, which is sort of related. The fact that if you repeat PPSV 23, even after at say 5 years after, you will have on revaccination some degree of hypo-responsiveness. You will never have the same degree of vaccine response and efficacy as you got with primary vaccination. Now, both these vaccines, the PCV 13 and the PPSV 23, elicit a B-cell mediated response. So that's a B-cell mediated response from both PPSV 23 and from PCV 13. However, what's special, what's different about PCV 13 is that it also has a T-cell mediated response. And why is that important? That's important because this T-cell response results in the maturation of the B-cell response, and more importantly, results in development of immunological memory. So in people who have not gone into immunosenescence, so around the age of 50, 60, when you're giving this vaccine, you're boosting immune response by giving the PCV 13 first, and you're covering more serotypes when you're giving the PPSV 23 8 weeks later, and covering the 11 extra serotypes that I spoke about.
Okay. So to summarize, it is always to give the conjugate vaccine first, that is involving the T cells, and then you give the second dose, the polysaccharide vaccine, which does not have the conjugate part, but it has a better coverage with another 11 actually. So it gives the thing. And again, probably 23 repeated makes some sort of immunocompromise actually. So 13 first, 23 has a good rationale, and it is being followed by, I think, everybody, every clinician. Now, Parvez, ACIP recently recommended something about this PCV 13 in elderly because the children mass vaccination is complete with PCV 13. So where are we? Where India are? Should we think this at the present or the future of our country? Mass vaccination of children with PCV 13. So does it make the elderly vaccination with PCV 13 redundant or really a necessity?
So that's a very important point that you raised, sir. And we are actually into the initial phase, infantile phases of introduction of the PCV vaccination in children across the country. And approximately of the 90 plus pneumococcal serotypes that we have known to cause human disease of the pneumococcal, nearly 67 and 70 to 78% of serotypes cause invasive pneumococcal disease in under 5 children in India. And they are present in the licensed PCV. And across the world, wherever evaluations have been undertaken, the PCV program has shown a substantial impact on the vaccine type strains of the pneumococcus. So as you increase the vaccinations, the vaccine type serotypes carriage and the disease as a result of vaccine type serotypes has reduced significantly. And this has happened consistently once we went from PCV 7 to PCV 10 and from PCV 10 to PCV 13. So since we do not have that kind of data available from the country, it seems likely that we are probably where the US was in early 2000s. And we are inching towards that. Probably the time is going to tell us that eventually the same kind of epidemiological transition is going to happen in India as well. And eventually there will be a reduction in the vaccine type serotypes of PCV, and then the non-vaccine serotypes will be more in number. And that will means that time we might have to relook at our vaccination policies.
So to summarize, mass vaccination of children with PCV13 does not preclude the elderly PCV13 injection at present in India.
At present, yes, sir.
And probably in future, even I think my personal opinion is that may be contested. So this is basically field evidence, but probably individualization may be done according to the clinician and patient interaction, whether one can be given both, even after 65, the 13 and 23.
So
Yes.
if we extrapolate the global data, and if we believe that that is going to happen to us as well, it is very likely that the vaccine serotypes are going to reduce in number, but only time will tell, as you rightly said.
Okay, Raja, now about this hyper-responsiveness by 23. We know that has been documented. So it's a documented thing, but someone wants to know, can you explain why this hyper-responsiveness is there by 23 and not by 13? Raja.
So I think in any B-cell mediated immune phenomenon, if you are repeating a vaccine after a definite period of time, there is a degree of neutralization. I think you talked about immunocompromise to an extent. So I think the immunocompetence of that particular individual is lowered when you're actually giving the vaccine challenge the next time around. And hence the immune response that an individual gets with a second dose or a third dose, even if it's after 5 years, is always going to be lower as compared to what you do with dose number 1, the primary dose of vaccination. And if you did a third time around, so 5 years again, I think the immune response is going to be even lower. So that's my understanding. I'm sure there are other people in the panel who could probably give a more scientific answer. Maybe Parvez.
I think it is nearly okay. Actually, any B-cell phenomena is there because they don't have the immune memory actually. Now I will come back to Dr. Abraham, Judge Abraham. Actually, we are not utilizing you to the best extent. Sir, what is the nephrology scenario? Is there any guideline from Indian Nephrology Society about this vaccination, pneumococcal influenza vaccination in say CKD, in people getting dialysis or in transplant patients? Dr. Abraham?
Yes, thank you, Professor Kausal. At the outset, I want to thank Rajathar and also Indranil for that lucid presentation. Now, when you look at the chronic kidney disease scenario in India, the prevalence is 17%, as we have published in Lancet. I was one of the coordinators of that in 2010. So if you have 17% chronic kidney disease in India, you are looking at 176 million people with chronic kidney disease at various stages. And what is the most common cause of chronic kidney disease? 31.2% are diabetic. So you have a diabetic burden which produces certain immunosuppression. And as you advance your chronic kidney disease, there is also an immunosuppression. So we do not know the extent of pneumococcal disease. Dr. Swaminathan will be able to say that in chronic kidney disease patients and in dialysis patients. But the most important thing is that we have incorporated pneumococcal vaccination into our guidelines in 2005 itself by the Indian Society of Nephrology. But the question is that I see a patient in my clinic. They have stage 4 or stage 5 kidney disease presenting for the first time. And then you talk to them about anemia correction, hypertension, diabetic correction, cardiovascular disease, and the importance of vaccination falls lower. So it is, they do have a hyper-responsiveness because as the chronic kidney disease advances, their immune system, there is senescence of the immune system, especially majority of the patients in this country. If you look at the CKD registry, it is 50 and above who are falling into the chronic kidney disease and who are requiring dialysis, and also who falls in the purview of transplantation. So we need to tell them about the most important three: hepatitis B, then pneumococcal, and the influenza vaccination, even though we have put in other vaccines, especially for children. So it is imperative, and we should have a pragmatic approach to patients with chronic kidney disease to ensure that they get this vaccination. But the only issue is that cost is a major implication. The moment you talk to them about pneumococcal vaccination, cost comes in because you need to take care of the other aspects, key issues in chronic kidney disease patients. So this adds to the cost. Hepatitis B vaccine is cheap. Influenza vaccine is also, compared to pneumococcal vaccine, I think slightly cheaper. So these issues have to be addressed to the patient, and we should, the 1,800 nephrologists in the country for a population of 1.38 billion should be active in promoting vaccination. Thank you.
But sir, I think the scenario is changing. I think it is easier now to make the patient understand about the cost-benefit ratio of being vaccinated rather than not being vaccinated, isn't it?
I agree.
It was very difficult, say, 10 years back. Now it is rather easier. The awareness has grown.
Yes, because I see that even patients who come for a second opinion from my colleagues, they were never told about, in their case sheet, nothing is written about pneumococcal vaccination. Even hepatitis B vaccination, a lot of them are not receiving. So it is important, and we should push it forward to make sure that importance is given to pneumococcal vaccination, and we should ensure that they get the conjugated vaccine first, and 8 weeks later the unconjugated vaccine. But hyper-responsiveness is an issue, but this should be taken into consideration.
Sir, can I ask a question? Just to sort of, so Dr. Abraham, just wanted to pick your brain. So suppose you have a non-diabetic, maybe a hypertensive.
Yes.
It's got non-oliguric chronic kidney disease and presents, say, at the age of 48.
Yes.
And maybe has a creatinine clearance of 40.
Yes.
Would you actually advise that this guy gets vaccinated?
Because he will have a better response rather than a patient who is in stage 5 CKD and dialysis. So I would prefer early vaccination in those patients. So they will have a better response, so that, they can mount an immune response.
Sure. Thank you.
Can I make a small point, sir?
Yes, please.
This is actually what Dr. Abraham says is slightly different from what the Indian Society of Nephrology guidelines on pneumococcal vaccinations, right? This is the only body of the Indian societies of physicians that have actually recommended pneumococcal vaccination beyond 65 years of age. Other societies have actually, all the other societies have taken the cutoff age at 50 years. So maybe one thing that probably Indian Society of Nephrology might have to relook at, given the fact that longevity or life expectancy in India till recently was only 50s. So now it is 67 years and 70 years in males and females respectively.
Yes, I concur with that.
Thank you.
Okay, I'll come back to Indranil. So Indranil, a little more, this controversy. 65 year age above, present scenario, will you give both the vaccines according to the protocol 13 followed by 23, or you'll give only 23? What is your stand at present, India?
So, okay, sir, if we go by the guidelines, so PPV 23 is something which is strongly recommended and is to be given to all people above 65 years of age.
Yes.
But again, looking at the theory, and we also have the guideline that has been mentioned that it is to be discussed with the patient and is to be given. The benefit and the risk is to be discussed. Again, the benefit has already been highlighted by Raja. That is, we don't have any herd immunity of PCV13 there because mass pediatric immunization was not done and it has been done recently only. Again, knowing fully well that PCV13 gives a T cell mediated effect, which is important for the B cell maturation there for the PPV23. So the recommendation should be that yes, after discussion with the patient, if the patient agrees, PCV13 is to be given, followed by PPV23, say 2 months to 1 year in the meantime.
It is not recommendation, isn't it? It is practice. Do you
practice
what you preach? The question is.
Yes, I do.
Okay.
Yes, I do.
I'll go back to Dr. Guleria. So, Dr. Guleria, this booster dose after 5 years, this below 65-year age and above 65-year age. So, where do we stand? This
I
booster
think Dr.
dose.
Aladhar explained it very nicely, the issue of hyperresponsiveness. And that is why over the age of 65, one is not usually giving a booster dose, and just one shot is usually given after the age of 65. There is a lot of debate in the literature if you critically look at the literature, and there's been some papers which suggest that this hyperresponsiveness tends to wane after 5 to 7 years. And there are some groups which said that we could consider looking at the vaccination, the PPSV vaccination later on. Current guidelines do not recommend it. And there are some guidelines which have suggested that, like in the pediatric age group, one could look at the antibodies in the blood. But we don't know what is the exact cutoff of antibodies in adults. We have a cutoff as far as children is concerned of 0.35 micrograms per ml in children, which says that if it is above that, you have sufficient antibodies. If below that, you should consider revaccination. So I think as per the current guidelines, we don't really revaccinate with after the age of 65.
Okay. Principle wise, Dr. Swaminathan, any comment on this? Above 65, say, booster dose after 5 years.
I have not practiced using the booster dose mainly because I'm worried about the attenuation phenomenon that has been very well described. And like has been mentioned, after 65, anyway, immunogenicity is very poor. I prefer vaccinating whoever needs to be right at the time when they're 65 or a little before that if possible. Because the longer you wait, the less efficacious the vaccine is.
Okay.
I have one other comment though. I think a lot of people are alluding to the ACIP guideline. If you look at the guideline, actually it says very clearly that the conjugate vaccine should be offered to people who live in areas where the pediatric coverage is very poor or circulating strains of the 13th valent are still very, very important. So please, I think even in the US, if you had an area like India within the US, PCV13 would automatically be on the vaccination protocol, irrespective of what it is. So I think there's some confusion about how the guidelines are to be read. Medscape has a very interesting activity which clearly explains how to use this data. If your pediatric population is not well vaccinated, I don't think it should be questioned at all.
Okay, coming back to Raja. So asthma is in a crossroad actually about this pneumococcal vaccination. COPD, yes. Even chronic smoker, yes. Asthma. Raja, what is your stand about pneumococcal vaccination in asthma? It is not the years, say below 65 or even below 50. Chronic persistent asthma.
So I think, like you've said, Dr. Ghoshal, the data about asthma is not robust. So prevention of infection in asthma as being a comorbidity is not as robust as COPD is or diabetes is or chronic kidney disease is. However, having said that, I don't think there will be any controversy about chronic persistent asthma. So if you have your GINA 3 and beyond asthma, GINA 3, GINA 4, GINA 5 asthma, to vaccinate these people, both for pneumococcus and for influenza, I think is something which is recommended. The controversy is more about the mild intermittent and the mild persistent variety of asthma. The jury is out. I would do it. I would vaccinate them in my clinical practice. However, I think there is a cost-benefit ratio that's involved. And I guess you take an individual call with the patient when you're dealing with GINA 1 and GINA 2. So the mild intermittent and the mild persistent asthma, I don't think there's very much data on that.
Parvez, something to comment about?
I agree with Raja. I mean, for a chronic persistent asthma, probably you would go for that. But for mild intermittent and the milder varieties of asthma, not much data is available. And that's where we don't have clear guidelines.
we may go to a little about the influenza vaccination, and I will start again with Dr. Guleria. So, in this COVID-19 pandemic, where do we stand with this influenza vaccination? As usual, going on, or should we try something different? Dr. Guleria, influenza vaccination at present during the pandemic? Any call, any
I think we
restriction?
should continue with it as usual. It's very important that we protect individuals from getting both COVID-19 and influenza, and therefore that can cause a huge problem in the high-risk groups. It's important to understand that both viruses are different, but they both are respiratory viruses and can cause significant effect as far as the lungs are concerned, and therefore both need protection or vaccination within their own rights. We don't have a COVID vaccine right now as far as India is concerned, and I think we should follow the seasonality chart, which has already been discussed. That we don't have a tropical vaccine. We either have a northern hemisphere vaccine or a southern hemisphere vaccine, and therefore, based on whatever the surveillance data has shown, we have to follow the pattern of influenza peaks. It's been said that the equator in India for influenza runs through Srinagar. So Srinagar is above Srinagar becomes the northern hemisphere, and below that is what we need to look at based on the how the monsoon behaves. In the early part, it's on the western part of India, and during the later part, it comes to the eastern part, Tamil Nadu, and therefore the vaccination has to be like that. And because of that, we've had this now availability of both the northern hemisphere and the southern hemisphere vaccine in our country. Many years ago, there was only the northern hemisphere vaccine which was available. It took a lot of effort by many of us to really push and get both the northern and the southern hemisphere vaccine available. And now I think the challenge that we have is to educate clinicians, especially practicing physicians, as to which vaccine to give when, because when both are available, it's very important for them to understand, and also to understand how to give it so that they don't get taken for a ride by the chemist, if I put it that way bluntly. Because very often the chemist will sell them the one which has the earliest expiry rather than seeing that what is required right now. So very often now, if you go for the vaccine, you will in the northern part, they will try and give you the southern hemisphere because that is going to expire somewhere in April, May, rather than the northern hemisphere, which will expire in the later part. So I think when we talk of vaccination, it should be as usual. But I think the huge challenge that all of us has is to educate our colleagues as to which vaccine to give when, and especially as far as the northern and the southern hemisphere is concerned.
Okay. There is a comment there about vaccine hesitancy. Practically, this vaccine hesitancy is more in the mind of doctors rather than the patients, actually. So you can say one of the purposes of this webinar is exactly that we have to rely on the scientific data that is available to us and make the country-specific recommendations. And so our recommendations are here, which have been published. So vaccine hesitancy is changing, actually, more acceptable than what it was before. But still, I think more to do about that so that it is acceptable to the ultimately the patient population. Patients are eager to accept. They know if we can explain to them the cost-benefit ratio.
So if I may just add here, it is a huge challenge, and not only among patients, among physicians also. I face that challenge every year when I tell my residents to get themselves vaccinated. I get myself vaccinated every year, and I think it's mandatory for all doctors to get themselves vaccinated, especially those working in critical ICUs and in transplant units, because you don't want to give influenza to your patients, and very often you could do that. But what happens is that when you talk to your residents, they will very often they would say, "Sir, I probably got it. I've already got influenza. I think I'm protected. I don't need to get the vaccine. As it is, it's a very mild illness." And because of that, I have actually changed the policy that I get the vaccine indented from our the employees area and get it put in the ward and in the OPD. And during the OPD, then make everyone go to the sister's room and get themselves vaccinated. But otherwise, there is a reluctance even among physicians. So I think we have a lot to do as far as vaccine hesitancy is concerned, not only in the general public, but among our own colleagues, because especially for influenza. They all feel that they've already had influenza and it's a mild illness. Why should they vaccinate themselves?
Should I ask a question here? Just a question that, for example, if someone from Delhi presents with an exacerbation and wants to get a vaccination, say in the month of November, December, where only the Northern Hemisphere vaccine is available, and we know that it is justified that we give a Southern Hemisphere vaccine. So is it justified that we give the Northern Hemisphere vaccine to the patient, or you should wait for the Southern Hemisphere vaccine to come for the next few months or so, and then call him again and give the Southern Hemisphere vaccine?
So my take on that is, I don't know what the group feels, that in such individuals, because of the fact you don't know whether he'll come back again for the vaccine, you should give whatever vaccine is currently available, which is for that situation. And therefore, don't wait till the new vaccine comes. If the patient is there and he is convinced that he wants to be vaccinated, whatever is the current available latest vaccine, give that rather than waiting for the next one to come.
I would agree with that, certainly.
Okay. Dr. Gloria.
So I have sorry.
Yes.
So Dr. Ghoshal, quick question. So question maybe
Yes, Raja.
to Randeep, to yourself, and maybe to Dr. Georgie Abraham. So you spoke about vaccine hesitancy about physicians. What about vaccine hesitancy or adult immunization from the government? You know, any thoughts about how adult...
Raja, we'll come to this at the end.
Okay, all right, okay.
No, but before that, I was thinking from Dr. Guleria that the residents, number one, do you pay them for the vaccination? This is number one. And even if they're reluctant, you can just pay them straight to get the vaccine. I think
vaccine is free for them.
Yeah.
The hospital provides the vaccine free for them. They don't have to pay for the vaccine.
Okay.
Not only that, the vaccine. So initially they were reluctant to go to the EHS, the Employees Health Scheme area, to get themselves vaccinated. So now I get the vaccine indented and bring it to the ward and to the OPD so that they don't have to go anywhere. Still they're hesitant to take it.
they need extra incentive.
There is
other money.
So may make a point, Dr. Ghoshal. This was an issue which was plaguing the vaccination programs, especially for influenza vaccine, even in the West, and they came with vaccine mandation.
Yes.
So it is mandatory for somebody to work in a
Absolutely.
particular high-risk area and make it mandatory for him to get vaccinated. And if he does not get vaccinated, he has to put a big tag that I am not vaccinated as a result of this and this particular reason. And it makes very difficult life for him. And he thinks it is better to get vaccinated rather than put a slew of reasons for not having gotten vaccinated. And vaccine
Okay, Parveen, so you're pushing the other way. I fully agree with this tactic. Anyway,
if I may say so, the point is we are underestimating the risk to the vulnerable people from people who have mild disease.
Yes.
People who have mild disease are not necessarily less capable of transmitting the disease. That's the problem. So the point is that vaccination has to be mandatory. At least where I was in Wayne State, at least, it was very clear. The rule is you don't have to take the vaccine. But in the 6 months, which is the flu season, if you are found without the mask inside campus, you're going to be in a shitload of trouble. They were very clear about that. And that's how punitive they are. They won't take away your right to take the vaccine.
Thank you. Well taken. Dr. Abraham, will you push that much for your kidney patients, the residents there working? Dr. Abraham.
Yes, the question of residents, we cannot sort of forcefully get the vaccination done. I haven't done that before, but when we do the rounds, we tell them that these patients have to be vaccinated, and we make a look at them and say that probably you should also get vaccinated. That's all what we can do, because unlike Professor Guleria, we don't have a free vaccination and they have to pay for that. And even if you request the pharmaceutical industry, they may give a 10% discount and not more than that. So we face the same issue with our junior doctors also in getting the vaccination done.
Okay, coming to Parvez, we have to be brief because we are nearing the time. Parvez, so for influenza vaccination, the trivalent is there, the quadrivalent is there, then 2 types of quadrivalent. What is your exact stand, Parvez?
So I mean, we know that the vaccine is basically predicted based on the surveillance data from various laboratories across the globe, and the quadrivalent certainly has an advantage of having an additional B antigen. However, the trivalent is yet there to stay. except if the pharmaceutical industries do not provide it to you. It has stayed in the West, and it should stay, because a majority, nearly more than 50% of the times, you could have a bee which is in sync with the vaccine strain. However, there is if the problem with quadrivalent vaccine is that even though it is certainly more effective against an additional bee's lineage, it's that much more expensive. And if we can actually get the cost of the quadrivalent down a bit, then probably quadrivalent would be certainly a superior choice than the trivalent. And talking of the subunit and the split variant vaccines, there are not very many head-to-head trials, but adjusted vaccine effectiveness for the split variant vaccine for prevention of medically attended respiratory illness due to influenza in adults more than 50 years was around 77%, whereas for the subunit vaccine, it was much lower at around 45 to 46%. So in terms of vaccine effectiveness for children, they are similar, and adverse effects are also not very greatly different. So both vaccines are there, but split variant vaccines are slightly more immunogenic, more reactogenic than the subunit vaccines.
Okay, but Dr. Saminathan, the live attenuated vaccine is still there. Any scope for that still now in India?
I think we have to be careful that, every hospital setting has a very mixed bag of patients. So if you have pregnant women, if you have people who are immune systems, you can't be using the live attenuated virus in that kind of a setting. So in my hospital, we do give the flu vaccine to all our high-risk employees, employees who are involved in high-risk activity free of charge. But we never use the live attenuated vaccine. In fact, in my hospital, it's completely banned because we have a significant load of transplant patients.
It's not available now, actually.
Absolutely. Even when it was, we didn't allow it.
Yeah, right.
Sir, just trivalent vaccine, is it available anymore? You cannot, even if you want the trivalent.
No, it's not available. It's not easily available.
No, he's talking of trivalent. Trivalent is available.
It's not available.
I don't think it is. Yes, I think Influvac had, the Abbott vaccine. I should not.
So the last one word, sir. If we are having an option of the split variant versus this surface antigen, if you have the option, so which ones should we take? Or both are equally, with the one that is cheaper, we can take that.
I told you, I gave you the background that the only study that has looked at the data in a head-to-head fashion, split variant was better than the subunit vaccine. But we don't have data from the Asian countries, especially from India. There is no data. However, whatever data is available from Korea, which is the nearest point that we have data from, that shows that it is equally immunogenic. And I think your own decision comes into play. Something that is slightly lesser in cost, but split variant is definitely more immunogenic in adults, especially if more than 50 years of age.
Okay. I have got a question here. This is a question for the future. I'm not very sure about it. That is, when do you space it with the corona vaccination? I don't know, honestly. Somebody has said.
Sir, these are all live attenuated vaccine. So practically they can be given simultaneously. And if not given simultaneously, a gap of 28 days is good enough. That's the only theoretically speaking.
If the messenger mRNA vaccine comes, I am not very sure about it. So the question is, how much time gap needed between influenza and corona vaccine? The answer is, I don't know. If anybody has any comment, he can. But anyway, there are multiple comments here about the age group. I think Raja has explained. Nothing is sacrosanct. Somebody has written it 50, somebody 59, somebody 65. Actually, this is a perspective. Practically, immunosenescence is there. Ideal, it should be at least 65. Better if it go back to 50. That is the thing. But we have to wrap up in quick time. So I think it is back to Rajesh, that do you still feel there is a chance of twice a year vaccination influenza rather than annual influenza vaccination in India? Rajesh Sarnakar.
So I think based on whatever discussion we had, that different parts of our country have also variations in peak influenza seasonality, and there's no uniform pattern for understanding the influenza vaccination, and of that cannot be maintained. So either I think the nation should be, of course, subdivided into the region-based what we call attitude-based, in fact, also this sort of schedule, as well as the disease of severity, or then we should go in for, I think, vaccination twice a year for a whole of the population, maybe one between April to May and another between July to September to cover the whole area. So this thing has to be actually considered. We may be able to dwell upon this based on evidence that we would gather, and I think maybe in future, instead of just once a year vaccination, we may go for, in fact, twice if there is no harm and if the data support. So I think that's what my take on that. But of course, we'll have to dwell upon that. I think during this also meeting, this was also considered, and as of now, what we had basically done that, considering India's large of landmass in geography.
We now recommend these guidelines. We have recommended annual vaccination, but probably it may be considered twice a year vaccination in the future, depending on the circumstances.
Yes.
I'll quote a question straight to Raja. Raja, this comment is GSI guidelines recommend PCV13 to all above 59 years. Okay, a shot of PCV13 followed by 23 after 8 weeks in high risk and after 1 year in healthy. So this gap, 8 weeks to 1 year. Raja, do you hear?
Yes, yes, I do. So I agree. I think if you have someone who is immunocompromised, the immune challenge needs to be greater, and hence the gap is shorter. And you would do 8 weeks or as close to 8 weeks as possible. However, in immunocompetent individuals with comorbidities, chronic heart disease, chronic kidney disease, COPD, and so on, somewhere near a year for the repeat dose, so the PPSV 23 is something that we would mandate, and that's what we have put into the guideline. So completely agreed with what you said, sir.
And Indranil, what is your opinion about this 50 years as the cutoff for influenza immunization in our country compared to 65 years in most guidelines? Please elaborate.
Just in short, again, in developing countries like India, we have already seen that after the age of 50, the influenza mortality is increasing to the tune of 3 or 4 times. So categorically, we have made the cutoff that 50 years should be where we should give the vaccination. And that's the reason in developing country like India, practically the risk benefit will be much more.
Okay. So somebody has commented about this, what is the spacing between corona vaccine and influenza vaccine? But there is a reality here. After getting out of COVID infection, what should be the time gap or giving the influenza or pneumococcal vaccination? Dr. Swaminathan, any comment on this? Somebody getting out from corona, can he be vaccinated immediately or after some gap?
We do that because after that, follow-up is a problem. You lose patients. It's best you do it when you have the patient. The best time to vaccinate is when the patient is in front of you.
Okay. I think Raya started with, I don't know, is Dr. Guleria still there?
Yes, he is.
Okay. Then what is the chance of government taking up this as seriously as child vaccination, this adult respiratory vaccination? Any thought about it?
So I think there is, many of us have been pushing for an adult vaccination program for years. And I think COVID-19 has actually shown us that why it is important to have a vaccination program. The challenge is that you have to be able to show that it's cost effective and that it is something that will save lives significantly. The evidence is there, but the only issue is you have to convince the government to put it on the priority list. When it comes to prioritization, sometimes it becomes much lower on the priority list. And often when I've talked to them and they start calculating the number, especially for an annual influenza vaccine, it becomes quite a task, because unlike the numbers when we look at children, for the adults, the elderly age group, and for those who have comorbidities, the number is quite large. As a matter of fact, that exercise is currently being done for the COVID vaccine. And for the elderly and those with comorbidities, the numbers are pretty significant. And if we add all healthcare workers, if you would like to vaccinate them also, and that may also imply for influenza, as we discussed, we need to really see how do we do it on an annual basis. And that becomes a bit of a challenge. One hopes that at some point in time, we will be able to have the holy grail of influenza vaccine, which is a vaccine which doesn't need to be given annually. There is some data which suggests that you can look at the extracellular portion of the M2 protein, and that may actually be a stable area, and therefore you may not have to give an annual vaccine, but I don't see that happening in the very near future. So as long as we have an annual vaccine, we have to continue to try and convince policymakers of the utility. But the whole program itself, implementation is a huge challenge. So at our own level, we can get the government to say that it should be given. But if it becomes a program, then it becomes the government's responsibility to roll it out. And then it becomes a challenge, because that means in all healthcare centers, in all primary health centers, we must have the vaccine available and enough vaccinators to vaccinate the entire adult population. And this population will run in a few crores. So we need to keep that in mind. But I think at some point in time, we will have to develop an adult vaccination program, even if it's going to be at a slow pace.
Thank you. Before wrapping up, anybody, any extra comment, anything, question to anybody else? Or we'll go for one word scenario. So I will start from Dr. Guleria. So how we can spread this message about adult respiratory vaccination further? Dr. Guleria, the roadmap.
I think this is a most opportune moment because of COVID-19 and the fact that vaccination saved lives. And it's not only now, it's been something that we've seen now for a very, very long time, both starting from various diseases in children to smallpox and polio. So we need to aggressively use COVID-19 as a platform to really push for adult vaccination as a program, and as to be able to show its cost effectiveness. That, I think, is the biggest issue that we have. And if we are able to develop enough database and sort of piggyback on COVID-19 vaccine, it will be something that will be very useful.
I think you have given us a very catchy phrase, vaccination saves lives. It is already there, or you have invented it right now? If it is so, we can use this. Vaccination saves lives.
Sure. I think it must be there.
So for future reference, Dr. Swaminathan, how to spread this message across the various groups, and of course, not only the government, the public as well.
Well, studies from various countries have shown that the number one marker of a patient taking a vaccine is the doctor recommending it. I think where we are failing is that we are not recommending it. And personally, I believe that doctors, when they themselves don't take it, they are less likely to recommend it to their patients. I believe the first target should be our own colleagues. We get our colleagues to get vaccination for themselves and their families. It will automatically roll out to the general public, to everybody else. Because like Dr. Georgie Abraham said, the problem is we are all very busy doing a lot of different things. And unless it's part of a checklist and something that we value for our own safety, we are not going to aggressively push. He identified things which he thought were very, very important. We have not identified this as being important to us, our own health. And as long as that happens, it's not going to move forward. I think this is an opportunity, like Dr. Guleria said, we need to use this with both hands and push hard.
Exactly. So the vaccine hesitancy is essentially in our mind rather than the patient's mind, actually. And again, Indian patients are usually abiding by the doctor's advice here. Usually we have better doctor-patient relation here, and we are not sued every other day. So probably it's a good thing to bank upon. Okay, Dr. Abraham.
Yes, I concur with both Professor Valeria and also my friend Swaminathan. And we need to educate our nephrology colleagues in our regional meetings and in our national meetings about the importance of vaccination, especially the pneumococcal, influenza, and hepatitis B vaccination. I think that's our only way of educating our colleagues so that this can be implemented in our practice, daily practice.
Okay.
And also, I think that patients also do not actually know where to go for adult vaccination, because they've got awareness to go for pediatric, they've got a pediatrician who would do that. But the patients have got no clue where to go for the adult vaccination. So again, that area has to be addressed, in fact, so that I think we got some defined location, site or location, which of course people can know if suppose they would like to go. Because I have got some incidences in which my patients have gone to pediatricians for this adult vaccination, because they are quite aware that they would get all these vaccines, because that's not our priority. As Dr. Swaminathan said, that it's not our priority, in fact. So we don't do that.
Okay. Rajesh,
If I may just make one suggestion, and this is something which is more from a maybe it's not from the medical point of view, but from a trying to give an incentive. I've discussed this with a number of GPs, and I've said, look, your pediatric colleagues make a lot of money out
Yeah.
of the vaccination program. If you really look at your adult vaccination and you start a vaccination program for your adult patients, you just need to have it in your fridge and you just need to give it, and you will vaccinate, you will save lives, and you will make good amount of money. A lot of pediatricians, their entire practice is based on only on a vaccination program.
Correct.
So I have actually tried to sell this to a lot of people, that it is also an incentive from you in terms of being able to make it part of your practice. And I think that is another it's sort of a maybe not a medical way to look at it, but it's something that may actually be an indirect incentive.
Definitely, yes. Actually, they talk it very openly in the West. We are not talking it that openly here. But yes, it is part of one of the things. Dr. Rajesh, so Indian Chess Society can do something to push this.
Yes.
Indian
So
Chess Society is all over the country.
yeah, so we have also discussed, this because we got a public forum website which is there in that. So of course we can geotag, of course, people who are ready to give this also vaccination, adults respiratory vaccination, if they're able to give. Actually, we can geotag them, and then of course people can know just by just putting their pin code number, and of course they can do that where of course they can go and also get this vaccination nearest to their site. So that is one of the ambitious project that actually I would like to do actually basically, and that is quite easy to do in fact, because we've got address, we've got pin code, address.
Okay.
Just take the consent.
Thank you, Rajesh.
Put it on the website.
Parvez, very brief comment.
Sir, just one small comment. I agree with the Professor Gure and Dr. Swaminathan. The biggest impediment to rolling out an adult immunization program in India is the hesitancy, is the poor sensitization of the healthcare workers. I'll give you a small brief example. We looked at influenza vaccination in pregnant females, and we found that of the 1,000 females that we recruited, that none had received, zero had received influenza vaccination. Whereas once we compared it with the tetanus vaccine, the uptake was 100%. And it was because, the obstetricians had not recommended it. So we need to focus, as Dr. Swaminathan stressed, on the healthcare providers. And once they stand sensitized, the rollout will be much easier.
But it's a changing scenario, Parvez. Do you agree?
I certainly agree. COVID has actually helped us a lot. And I would say the influenza uptake in our institution has gone from nearly 4% in 2012 to around 85% this year.
Okay. Indranil, how much do your bit in writing influenza and pneumococcal vaccination to your patients? What is your practice?
That in fact, I follow the guidelines. I do the soft copy is when I do the prescription in soft copy and it is printed there. In fact, people in whom vaccination is recommended, that is checklist is there. I do tell them and from where they can get the vaccination, and I practically provide the vaccination and give the vaccination in majority of the time. That's the real thing that I can do.
Excellent.
Also a pediatrician, so I think he has learned from.
Yes, I had that experience.
He is a combined pediatrician and pulmonologist, so he knows it better.
He's become wiser. Yeah.
Okay, yes. Raja, your final comments?
So my final comment, I completely agree. I think it's the conviction of a physician which gets transferred onto a patient. And I agree with what everyone said. The other thing I wanted to say, I think relevant for this meeting that we are holding today and you are hosting, Dr. Ghoshal, is that while it's important to write guidelines, what is even more than important than writing guidelines is dissemination of guidelines.
Exactly.
Yes, this is one effort which is aimed at it. And I think we need more such efforts which involve physicians from throughout the country on platforms like this, where we talk about it, discuss about it, and it gets ingrained into people's psyche. I think this is a great effort, but this is just start of an effort and we need to continue in the same way.
I accept it, Raja. We know that one webinar cannot change the practice. But again, one webinar can open this. Further discussion, further webinars and further small meets. So ultimately it is the propagating the awareness and again, execution. Practically, once it is executed, it gains momentum. If one practitioner does right in that locality, others will follow suit. This usually follows. There is no much more comment there. And somebody is writing about COVID. I am not entertaining it. I am sorry, whoever is writing, can a COVID patient recover, take COVID vaccine? I'm not discussing COVID purposefully. Please don't. So stay to influenza and pneumococcal. We have discussed a lot, and I have promised that we will finish in time. So we have just crossed it. So I think I have to thank everybody who have been here today. Dr. Guleria, again, very busy schedule, but you have made it, sir. We are really grateful to you. Dr. Swaminathan, Dr. Abraham, our own people. I consider Parvez as my own. I don't know what he thinks.
Certainly, sir. Thank you.
Dr. Rajesh Sandakar, Dr. Indranil Haldar, and Dr. Rajadhar. So everybody has done their bit. And again, I think this is not the end. This is the beginning, actually. We'll try to propagate this message in every forum that we can, even in coming NAPCON, in other regional meets, and again, all the specialties. What is the good thing about this guideline was we included not only different parts, but different specialties together. It was not just a pulmonologist guideline. We included diabetologist, we included nephrologist, we included infectious disease specialist, and everybody together. So let's have it a go. And thank you all for a very good, entertaining, and fruitful evening. Thank you.
Thank
And
you, sir.
then,
Thank you so much.
Raja,
Thank you.
anybody to thank? Indian Chess Society, of course, again, I consider myself as an integral part of Indian Chess Society and forget to thank it separately. But
And
of course, yes.
I should thank
Rajesh.
Maki, in fact, and I think we should have much more good association between your organization and us, and all these organizations, when they come together, I think dissemination of also knowledge becomes more. So thanks to also Nabi for being associated with ICS. Thank you.
And a word of thanks for our sponsors. So we've been
Yes.
supported by Pfizer in doing the meeting today. So a big thank you to the Pfizer team for supporting us in doing this meeting today.
Thank you all.
Thank you.
Thanks, everybody. Good evening. Good night.
রয়ে গেলাম আপনি আর
আমি চলে গেলাম।
না, আপনি যাচ্ছেন কোথায়? তো আমরা রয়েছি। ঠিক
ঠিক
আছে,
আছে। আমি আর তুই।
আমি আর আপনি, আর তো কেউ নেই।
আরে রাজা, এটা খুব ভালো হয়েছে। আচ্ছা কি তোর এটা ভালো হয়েছে, তোর ওটা তো বড্ড ম্যাটার আছে আর কি। ম্যাটার
ছোট করে দিয়েছি স্যার আপনার জন্য। আপনার আমি তো 10 মিনিটে বলেছি, আপনাকে আমি 15 মিনিটের জন্য তৈরি করে দিয়েছি। আমি হাইট স্লাইড করে দিয়েছিলাম সবগুলো।
ঠিক আছে, ঠিক আছে। না, থ্যাংক ইউ ভেরি মাচ। ঠিক আছে,
ঠিক আছে।